The following podcast is part of a certified educational activity titled The Power of Personalized Medicine in AML, linking individualized treatment to enhanced patient outcomes. Access the entire activity and complete the post-test at peerview.com/NQY860. Downloadable slides and practice aids are also available.
Hey, hello, yeah. Thank you all for running from the other session to this one, as I did. Looking forward to the discussion, switching gears from the MDS discussions we had to acute myeloid leukemia, and it's a great pleasure to have my colleague and friend, Dr. Amir Fathi, who will be leading this discussion with me. So very briefly, I'm going to give an introduction. Acute myeloid leukemia, very exciting progress over the last 5 years. I mean, a lot of the molecular and biological progress happened over the last 2 decades, and we have to give credit to a lot of that work that led to the eventual culmination of approvals. And these are the 9 therapies that have been approved now in the last 4 to 5 years, and in fact, many others are in advanced phase 3 development that we hope will also join this group of therapies in the near future. Still, we have many unmet needs. The overall survival today for a newly diagnosed AML, if you take all ages, is still probably in the 35-40% range. So even though we are making progress, we still are way behind, for example, the ALL and multiple myeloma colleagues. But hopefully things are improving already with these new drugs available, and we'll talk about some of the applications of them. I think one of the key things in a plug we want to put in here is for clinical trial enrollment. This statistic is sobering and actually quite depressing, showing that in the patients who are diagnosed in community real-world setting with acute myeloid leukemia, 600 plus patients, we see that many of these patients, 60%, 2/3 of patients, did not receive any therapy. Now, hopefully this will change in the last 5 and oncoming 5 to 10 years with the advent of venetoclax, FLT3 inhibitors, IDH, many of which are specifically designed to be given to older, unfit AML and have been found to be effective and safe. But this is the data we have. And as you see, genomic testing, we talk about it all the time, but only 13% had this. So that's quite sad, and hopefully will improve. A lot of educational activities like this one are pushing for genomic testing and integrated off-targeted therapies. And then COVID, of course, did not help matters. Clinical trial enrollment has dropped. But we at MD Anderson and other centers, Dr. Fathi will discuss, are actually seeing a rebound of referrals and increasing numbers, and hopefully this will allow many of our trials to get back on track and hopefully culminate in new approvals of therapies. With that, I'm going to move on to the presentation here. So we're going to kind of divide this by cases, and we're going to try to talk about these cases. So for this first one, I'm going to present this older patient with therapy-related acute myeloid leukemia. 75-year-old patient has a bone marrow confirmed acute myeloid leukemia. Let's say had some form of prior chemotherapy for another prior lung cancer, lymphoma many years ago. Very common group. You know, we're seeing that people with other tumors are living much longer, which is great, but it also means that we're actually seeing a lot more therapy-related AML in the last few years. We do mutation analysis. We find ASXL1, RUNX1, MLL. MLL is quite common in patients with prior topoisomerase inhibitor exposure, ECOG performance status 1 or 2. So here I'm going to throw it to Dr. Fathi to see what would be his thoughts on the 75-year-old patient. Consider venetoclax, consider other options, transplant soon. What do you think?
Thanks so much, Naval, for having me. It's great to see everyone here after so long a period of not going to meetings and seeing a lot of you. It's very nice to see you, and I want to thank folks for having me on the panel, and also to be here with Naval is wonderful. So 75-year-old therapy-related AML, performance status of not so great, maybe 1 to 2. Generally, the conventional approach for this patient is a combination of hypomethylating agent, either decitabine or azacitidine, plus venetoclax. That's typically the recommended approach. Of course, there are other potential options, low-dose Ara-C, and venetoclax is also another potential option. Let's say his performance status is 1 and he looks pretty spry to you. I don't think pursuing intensive therapy is wrong necessarily in a 75-year-old. We've induced patients in their late 70s and 80s, depending on how well they've looked. Perhaps we're in the minority, but we have on certain situations. And then the remaining question there is subsequent transplant, which is just a topic that Naval and I were discussing earlier today, which is, would you pursue a transplant in a 75-year-old? I told them the story, which I guess it's not wrong to repeat here. We had a patient present to our cancer center. She looked quite fit. She was 78. We gave her treatment. She went into a remission, and after much debate, we did a bone marrow transplant, and she did great. She was from another country, didn't speak much English, and a few months after the transplant, we found out that she had fibbed a bit, and actually she was near 85. So it just goes to show you that transplant modalities, I think, have advanced and have changed a bit in the sense that they are more and more tolerable, and perhaps are more broadly applicable to a wider group of patients.
So I think Dr. Fatih just convinced the transplanters to look at the birth certificate or driver's license.
Background check, yeah.
But no, I think for a 75-year-old, honestly, I would say that we would treat all of them at MD Anderson on a HMA, VEN, or some form of VEN based regimen. We'll discuss later some of the Clad-LDAC-VEN combinations, etc. We really have moved away from intensive chemo. Yes, there's the occasional 1 or 2% core binding factor isolated NPM1 where if it's a marathon runner and we're going for a 5-year 80% cure, we would consider it. But I think VEN-based is really where 98, 99% of these patients would go. And I totally agree with you. We've had a lot of discussions with our transplanters in the last few months. And just like in leukemia, there's a lot of progress in transplant. They have better GVHD medications. They have T-cell therapies for many viral infections post-transplant. And they're actually very comfortable now. They told us to consider up to 77, 78, which a decade ago was about 72, 73. So we refer all our patients up to 70, 78, 77, 78 to consider transplant, and that's probably the approach I would do here, VEN-based and then transplant, and then go from there. Now on the other side, you have a little bit different patient, also has a secondary AML, prior MDS, was on erythropoietin alone, has the bad actor cytogenetics, deletion 7, deletion 5, ASXL1. So we see these with alkylating agent prior exposure. And the question here is now, what would we do? Would we still consider VEN-based? Would we think here now CPX or 7+3 and the role for transplant? So Amir, your thoughts?
So yeah, this situation is a little bit different. I think the goal here in the back of my mind is always, how do I get this patient to a stem cell transplant? It appears that based on at least the limited amount of information we have, this patient is a potentially curable patient with a number of sort of high-risk features, secondary AML, ugly mutations, ugly cytogenetics. So the general approach is to try and get them to transplant. CPX-351 is approved for patients with secondary AML that sort of fit in this age group and sort of fall into this category. So I think that is a very reasonable option. I would say that there are some centers that even would consider potentially giving venetoclax-based treatment for these patients, the goal of which is then, again, still to follow with a transplant in the hopes of curing them. But as was mentioned earlier by Dr. Daver, we don't cure most of our patients still, right? So, the 50 or 60% of patients that are not cured oftentimes, unfortunately, fall into these categories. So the goal is really to drive down the disease as much as possible, followed by stem cell transplant to cure them. So just some NCCN guidelines data. This is just to sort of focus our attention on older patients. Of course, if you have targetable alterations, favorable risk cytogenetics, FLT3 mutations, there are some caveats to consider, but our focus is really on the bottom two categories there, those patients who have secondary AML and are fit for induction chemotherapy, and those who are candidates for HMA-based, venetoclax-based treatment. All right, so let's talk about CPX. CPX is a 5-to-1 molar ratio, a liposomal product of anthracycline, daunorubicin, and cytarabine. So cytarabine 5 to daunorubicin 1. And it's important, even though CPX doesn't have the sort of anthracycline in its name, it's important to be mindful of lifetime anthracycline dose. So if patients have previously received anthracyclines for whatever cancer, it's important to keep that in mind. The initial data that emerged was approximately 6-7 years ago with randomized phase 2 data, and then phase 3 randomized study looking at secondary AML, both therapy-related as well as AML with MDS-related changes, demonstrated a survival advantage followed by approval in patients that sort of fell into that category. Although the trials were age-limited, the approval was more liberal and applied to all patients who were induction eligible. So this is data that actually is relatively recently presented or published in Lancet Hematology, looking at the 5-year results of that phase 3 trial. And you see the survival curve there on the left, based on sort of from the time point of randomization, showing the fairly impressive and sustained survival advantage of CPX-351 over 7 and 3 in these high-risk secondary AML patients. The box on the right has a red, there's a red box around it, and it's highlighted. And I think and the reason for that is I think is sort of where I think my interest actually lies here, because these are patients that made it out to transplant, and folks that made it to transplant with CPX-351 did much better than individuals who did so with 7 and 3. So that too is a remarkable finding. You know, almost 50% of patients who were transplanted after CPX-351 had long-term survival. So that's a crucial element to the potential promise of this agent. So looking at younger patients aged 60 to 69, again, you see the survival advantage of CPX-351. This is a recent Blood Advances paper looking at older patients, again, 70 to 75. These are folks that generally have poor outcomes with any therapy historically, but there is a very wide difference. Again, this is subgroup analysis, but shows you that the survival advantage pretty much carried over in various age groups and by various analyses. Okay, so the challenge is you have effective therapies that broadly apply to overlapping population of patients, older patients, let's say. And do we know the answer, for example, of whether azacitidine or decitabine plus venetoclax is better or worse than CPX-351 for, let's say, an older patient who is fit? Or you know, perhaps a slightly younger patient with comorbidity that you're debating whether you want to give them CPX in the hopes of trying to take them to transplant. There were 2 retrospective studies that were presented at this last year's ASH meeting that were not prospective, but were looked at multiple centers, and they demonstrated some interesting, though not definitive results. There seemed to be in one of the presentations that was presented from a consortium of Cornell, Northwestern, Moffitt, and MSK, that the overall survival seemed to, the advantage seemed to be with CPX over venetoclax-based platforms. However, it did appear that the majority of the benefit was driven by transplant. And it's not surprising because there was a bit of an age discordance, right? So most of the patients on these retrospective analyses that received CPX were younger, and most of them that received Ven-HMA were older and probably not as likely to be transplant candidates. So in patients who did not go to transplant, outcomes were the same between CPX and the HMA-Ven arms. Another study that was also presented, I believe, led by the Penn group, showed very interesting findings, fairly similar idea, that there was, at least in this study, there was a similar overall survival, but the use of transplant was critical for overall survival benefit in these patients, and the therapeutic choice did not influence survival when you controlled for transplant. And as you see there in that Kaplan-Meier curve on the left, whether you received Ven-Aza or CPX, but went to transplant, those top 2 lines, like you could make the argument that Ven-Aza may be a little bit higher up than the CPX arm, though that ultimately was the determinant of how well or not well these patients ended up doing. Again, retrospective studies. Just a plug for one of the trials that we're doing, along with many collaborators across the country. We're conducting a prospective study now of comparing Ven-HMA versus conventional induction, whether it's Vyxeos or 7 and 3. It's a randomized phase 2 study to hopefully better answer this question in prospective fashion. So some practical points regarding CPX. It's approved for patients 18 and up who are induction eligible. And I assume it says here in pediatric patients. I don't know as much about that with therapy-related AML and AML with MDS-related changes. In the phase 3 study, I always say CPX is great in sort of the front end of treatment. There are less GI side effects, less mucositis, and almost no hair loss. Patients just, fly through it. The first week or two is grand. There is, as a result, I think to a certain degree, less 30 and 6-day mortality. The challenge with CPX, of course, is sort of the back end of that induction course when you have prolonged neutropenias, prolonged thrombocytopenias, and the risk of complications from that. And that's an important consideration. And obviously, importantly here is the composite remission improvement and the overall survival advantage that led to the approval of this agent. So just to sort of finish up this here, next steps with CPX, there is an ongoing VFAST trial that is looking at CPX with multiple different partners, including a FLT3 inhibitor, IDH inhibitors, and venetoclax. Some early data was presented that looked at decently interesting composite remission rates when CPX was combined with venetoclax. But I think we need additional data to sort of move forward from that. Okay, so on to the next case. Before I do that, I just want to just ask my good colleague, Dr. Dover, if he had any additional thoughts or questions regarding the slides that I presented that have come up, and we can maybe go back and forth and see if there is anything else.
Yeah, I think while people are answering questions, so I think that's really fascinating data, right? That basically what really matters is getting people to transplant in remission, whether you do it with a VEN-based or CPX, at least in those two. And we have to acknowledge these are retrospective, multi-center, but the effort was made, which is good. It seemed like both were valid. I want to commend you, Amir, for the study you're doing. I think this will be a major, important milestone study either way, right? AZA-VEN versus intensive chemo in 18 to 75 population with intermediate high risk, because if that is even equal in my mind, and for many of us at MD Anderson, I think this will potentially put chemo for a majority of AML, not all, at rest to a large extent. So I think this will be very critical data. But today, as you said, we do consider CPX in the fitter patients with transplant, but HMA-VEN also remains one of the kind of top options. Yeah.
I think there are so many remnant questions around these topics, right? Intensive therapy versus less intensive therapy. We didn't really have less intensive therapy options that were effective 10 years ago. We do now. Can we bring that to the larger group of AML patients? That's an open question. The fact that these retrospective studies seem to suggest getting to transplant is the key to drive survival suggests to me, perhaps, we don't know, and that's part of this attempt to look at this a little bit deeper with this prospective study, that there probably is not that degree of difference between depth of remission among the two patient populations, because oftentimes MRD negativity depth of remission is what drives success following transplant. So we're hoping to show that also with this study using NGS and both flow cytometry as MRD assessments for patients who are receiving therapy prior to transplant. On top of that, there are quality of life issues, right? So I'm sure patients are much happier, despite how easy or difficult an induction regimen is, to receive that therapy at home without having to sit in the hospital for up to 40, 45 days. So I think that part of it is also important. And one final thing I will say, it's an aspect of the type of work that Naval and his colleagues are doing, is doublets. These outpatient regimens are really the framework upon which you build the triplets and quadruplets and the triple somersaults and everything else that sort of follow along, and the future of therapies for AML and diseases like it. So anyway, I think it's an exciting period. And with that said, I have 12 seconds to move on to the next clinical consult. So George, a 75-year-old patient presenting with therapy-related AML. He has IDH1 mutation twist and a RUNX1 mutation along with his MLL or KMT2A rearrangement. But testing also confirms the presence of the feared and hated TP53 mutation along with the performance status of 1 or 2. So this is something that Dr. Daver and I are going to discuss here. So what are the options for George? CPX, is that an option? Venetoclax-based therapy? Jump to transplant, or what do we do with transplant, or is that an option, or does it work? Or are there other approaches that may show promise, many of which Naval is very familiar with? So I'll ask Naval, what is your, let's say you have this patient, 75 years old with this sort of range, what is your approach to this patient?
Yeah, so I mean, it's not that uncommon really to see TP53 mutation having some other potentially targeted, about 50% of TP53 are isolated, have nothing else, but we do see sometimes IDH, very rarely FLT3 as well, and always the question is which mutation to kind of target first. In most experiences, TP53, especially at a higher allelic burden, above 20, some studies have shown above 40, becomes the driver mutation for the outcome, the clinical outcome. So for this patient, if I have trials available at MD Anderson, we would today go for a CD47 based approach, whether it's with Marrow, which has more data, but there are others out there as well, ALX, TTI, and very much try to move to transplant quickly, potentially even within 2 cycles, achieving marrow remission. This is the patient where I would not wait for the ideal MRD negativity. The saying is, do not let perfect be the enemy of good, because we know that only 10% or less will achieve MRD negativity. So if we can get them into a marrow remission, controlled state, get to transplant, there's actually a lot of emerging data. Charlie Craddock and the British group have published, our group has published, Dr. Oran and others, that you could have about 30-35% long-term survival. It's not great, but it's better than 0 to 5% without transplant. So that's kind of what I would probably try for this patient today.
Yeah, I mean, I agree. It's just difficult. I mean, P53, we don't have an answer. And I think probably the best answer is to get him on a clinical trial with a novel therapy combination with HMA. But short of that, we've tried everything. We've tried AZA-VEN, decitabine-VEN, 10-day decitabine, CPX plus something. He has a target IDH1. You could potentially try combining that, adding that. So it's sort of it becomes difficult because you're desperate to get these patients to transplant to buy time. There is some data coming out of Moffitt mainly that says driving down the P53 clone might lead to success following transplant, but that's difficult to assess, of course, because you may just be selecting for patients that are more likely to respond, and therefore that's why they also have better outcomes following transplant. So I agree that the sooner you can get patients to transplant, the better chance you have for them to have success. So with that, I'm going to hand over the platform here to Dr. Daver to go through some slides.
All right, thanks. Okay, so thank you to Dr. Fatih. I'm going to go through some of the data in TP53. It's all unfortunately quite depressing, so hopefully you're all eating dessert now, because this may put a sour taste. But unfortunately, HMA-VEN or VEN-based therapies, which we all hoped 3-4 years ago at SOHO and similar meetings, we were all excited, response rates were great in every molecular subset, and we hoped that would pan out to survival. And unfortunately for TP53, didn't. Pretty much every other molecular subset has had some degree of benefit with VEN-based therapies. It's different with NPM1-IDH1, where the benefit is huge. FLT3, there's some benefit, but with TP53, I think we're kind of really back at the drawing board back 5 years ago, where we're ending up with survival 5 to 7 months. 3 different data sets have now shown this, the phase 1b, the phase 3 VIALE-A subset analysis, and then our MD Anderson decitabine 10-day venetoclax, all 5 to 7 months. So we really need to find other strategies. Then the hope was maybe CPX has this unique liposomal formulation, better bone marrow penetration. Maybe there will be something special for TP53. And actually what we found was TP53 was one of the main subsets that had almost no benefit. Again, in the mutated, you see 5 months survival with both CPX and 7+3. In fact, the non-mutated seem to be the ones that actually were overall doing better. And you can see that there is a tail there at about 40%. So, what about allogenic stem cell transplant? And I think this is a very tricky area. People come to these meetings or talk to people and with the idea that we should not do transplant. And I absolutely don't want to say that we should do transplant TP53, but the transplant outcome is poor. The outcome without transplant is horrible. It's pretty much close to 0%. We have very, very, very few patients who are alive. So transplant still has a curative potential. It's not a huge curative potential, but 3 different data sets now in the last couple of years have shown 35% or so can achieve long-term survival in TP53 mutated who move to transplant with whatever approach. Those are probably the little bit better actors, people with low allelic burdens, things like that. But our approach today at MD Anderson and many other centers are looking at using some form of therapy, debulking disease, moving to transplant, and then potentially doing unique novel approaches post-transplant with maintenance, whether it's with HMA-based maintenance or new cellular therapy maintenance approaches with NK cells, DLIs, etc. So I really think we should transplant these patients if we can get them debulked and work closely with our transplant colleagues. What about some of the new approaches that we hope will have some breakthroughs, especially for TP53? So the one that at this point is the lead is a CD47 SERP alpha. This is a macrophage immune checkpoint. We discussed this a lot in the MDS session because in fact the MDS study, the phase 3 of 500 plus patients just completed accrual last week. So we will hopefully see that randomized phase 3 data in the next few months. But in AML, there are efforts as well. And so what you're doing here is you're basically kind of trying to harness macrophages by releasing them from inhibition and allowing them to attack the tumor cells. So this is the data that was most recently updated from the single arm study. A randomized study is ongoing. And here you see the overall response rate is about 50% with a true CR rate of 33%. With HMA-VEN, we see a true CR rate of about 25%, maybe a little bit better. I think the advantage here is it's less myelosuppressive, neutropenia, thrombocytopenia, and we are able to get patients to transplant. If you can transplant them, again, the recurrent theme, that's really where you start seeing 1 and 2 year survivals of close to 50% or more. And the study right now is now into a randomized study of about 400 patients of aza-magro versus aza-ven or 3+7. So it's going to be the first kind of TP53 target approach. Investigators can choose whether they want to give intensive chemo or HMA-VEN as a comparator. And that study is probably going to take a couple of years till we see the data, but the enrollment is ongoing. So just to highlight that point, you know, as a single agent, all patients, 11 months, on its own doesn't look that great, but when you look at it in the setting of HMA-VEN or HMA alone, about 5 to 7 months is what we got. So there may be some improvement, and I think in TP53 we have to look for these incremental improvements, but again, getting to transplant has a big impact on improving that survival more towards a curative rather than a few months median outcome. So I think with that, let me ask Amir if he has any thoughts or questions that we want to take.
I would love to get your thoughts specifically. You know, some of the data that you presented here is highly promising with a very nice median overall survival for this challenging group, a nice duration of response. I think something that's in the back of people's mind is as you collect more data, collect more patients, we hope and anticipate that that will stay steady. How optimistic are you that CD47 antibodies or SERP1 alpha targeting agents in combination with HMA are really going to move the field? Do you think that that is the class of drug that's going to do it over time?
So I see a lot of investors are taking their books. So
I'm just curious. I mean, I think for all of us, we're
curious.
I
was actually just on a call yesterday with some of our European colleagues. And is it going to be a breakthrough like, overnight we're going to cure? Absolutely not. Will there be incremental benefit, few months? I think yes. But I think that's the realistic proposition we have to look at, right? For 3 decades, we've all been kind of looking for the silver bullet. It's not there, and even in preclinical work, there's nothing that suggests it's going to be there. So if we get a few months from this, then we develop NK cell strategies, we get a few months from that. I mean, if you go to the ALL session, I think this is the reality of how they achieved it, right? You add the ENO, you add the BLINA, you adjust the dosing, you bring the CAR-T. So I think that is the eventual approach. And hopefully, at least we get some marginal progress, and then we can build on that. That's kind of what I feel.
The other consideration also is that as sort of time passes and we learn more about P53, we sort of learn also there's P53 and then there's P53. I think the location of the mutation matters. I think the amount of allelic burden matters. I think the presence of complex karyotype prior treatment matters. Co-mutations probably matter. So some patients with P53 mutations will do better than others, and I think it's on us to try and figure out who will and who will respond to these sort of combinations over time. So a lot of my colleagues and a lot of folks that I've talked and worked with over time, when they see P53, oh my God, we're done. I don't know if that is the case necessarily in every instance. It's just that we know it's a bad player, but we don't know enough about it to help hopefully prognosticate uniformly for patients.
Yeah, I mean, if anything, I think APR and Marrow have at least put TP53 in the forefront, right? 5 years ago, you would see a minimal discussion in the corner, 2 minutes. So now there's a huge discussion, and usually it's those efforts, maybe it's not the first or second shot, that will eventually lead to progress. We saw this with FLT3, with MLL. So that is hopefully what will happen in the next few years for TP53. So now we'll move on to the targeted platforms here. So I don't know, do we have, okay, so we have a case here. So this is now looking at a patient, 70-year-old, has clear comorbidities, hypertension, CHF, stents, diabetes. So definitely a 70-year-old, but kind of older 70-year-old. Bone marrow 75% blast, diploid cytogenetics. And the question here are, what are the options for this patient? Venetoclax-based therapies, other low intensity, whether it's with VEN or other low intensity approaches. And then provocative question, of course, what if this patient had an IDH1? And of course, this is getting at the agile data that Amir will be discussing. So I'll turn it over here to you, Amir, to kind of discuss these aspects.
All right, I'm going to try and speed up a little bit because I think we've just been having too much fun up here. So we're going to talk about specifically patients without actionable mutations and what our options are at this point. Here's some of the data from the NCCN guidelines and try and sort of hammer in a little bit. All right, so pretty much for every AML doc, these curves are sort of somewhere in the back of our brains. So we've seen them so many times. The combination of VEN-AZA versus AZA and placebo showing marked improvement in overall survival for the former. 15 months median overall survival. That's remarkable considering the fact that these patients were either 75 and up or had marked comorbidity. And on top of that, we're talking about a composite remission rate of around 65%. Actually, you don't probably ask for much more than that with traditional induction therapy in this age group of patients. So this is a big accomplishment in terms of advancing our field. It is currently, I would say, the conventional approach for newly diagnosed AML patients who are older or for whatever reason due to comorbidity or functional status are not appropriate for intensive therapies. It is well tolerated with a good 30-day and 60-day mortality. It does not come without risk. So this is something I repeat a lot at various educational sessions. So azacitidine and venetoclax, decitabine and venetoclax, they're not the same as azacitidine alone or decitabine alone. They're much more marrow suppressive. They're different in the time to response. Usually you gave AZA to AML or MDS patients. You did a marrow at 3 months or 4 months and see if you had a response. Sometimes you did, sometimes you didn't. With HMA-VEN, you can't do that. You can't take your hand off the wheel. You should do a marrow very early to see whether you've emptied out the marrow, because if you keep treating every 28 days without looking, it can lead to significant neutropenias, thrombocytopenias, and complications, and we'll talk about that. So early bone marrow assessment, interruption of venetoclax if there is marrow, the marrow is ablated or empty, especially in patients who have cleared their blasts, particularly so, is recommended. You delay up to 2 weeks and then resume when there is some count recovery, and I would recommend actually reducing the duration of venetoclax by that point, although there is some debate around that, but that is my general approach. Reduce the duration from 28 days to 21 days, and then subsequently may have to reduce it to 14 or even 7 in subsequent cycles that sort of come along. The goal is, in patients in whom you give azacitidine and venetoclax, is to make sure that they can get this therapy continuously, not to just hammer their marrow every 28 days. You're trying to get them to a response and to keep them there without getting hurt, especially in this patient population. So this is, again, basically saying what I just said. So hypermethylating agents are generally given for the first 5 days in the case of decitabine, 7 days in the case of azacitidine, and the duration of venetoclax is 28 days, and the dose of venetoclax is 400 milligrams, although that is reduced if you're on a concurrent medicine that can impact CYP3A enzymes such as azoles, but also other medicines too, in which case you have to reduce the dose of venetoclax. And then you monitor these patients closely. Some institutions give antimicrobial prophylaxis. We don't in Boston, but many do. I think that is an approach. In the first few days, monitoring for TLS is recommended, although I would say the risk of TLS is pretty low, but it happens, and when it happens, it can be pretty ugly. So generally, we recommend hospitalization for the first 2-3 days. It's rare that I don't do that, particularly in patients who have a higher white blood cell count. And as I mentioned, this is not HMA alone therapy. Patients will drop their blood counts. They will require transfusions. They will need to be monitored for fevers. And even though it's an outpatient treatment, many patients end up getting hospitalized if they have an infection or a fever. The timing of the bone marrow biopsy in the first cycle is important. It says here day 28, but that's towards the end of the cycle. I typically do it earlier than that. So I have that data at around day 28 to 29 to make a decision about when I'm going to start cycle 2. So I usually do a bone marrow biopsy around day 23, around there. And if the marrow is empty, I hold the venetoclax and I give them time to recover their counts before I hit them again with another cycle of treatment, because as I mentioned, cumulative marrow suppression is a big problem. And for the subsequent cycles, I reduce the duration of venetoclax if neutropenia and thrombocytopenia are issues. And the same applies for subsequent cycles. Subsequent cycles, you don't, I forgot to mention, there is a dose escalation during the first few days of treatment, 100, 200, 400, or the appropriate dose for concurrent azoles. You don't need to do that for subsequent cycles, and the duration of venetoclax may need to be reduced. And usually by the end of the first cycle or end of cycle 2, the marrow should demonstrate suppression of blasts, either an MLFS, a CRI, or if you're lucky, a CR. Most individuals will get that by the end of cycle 2. If they don't, that's not the best sign in the world. Although I will say that I had a patient not too long ago who achieved his remission after cycle 4. So because this patient, I believe if I'm remembering correctly, had an IDH1 mutation, it's important to also mention that there is another kid on the block, ivosidenib in combination with azacitidine, was just recently shown in a placebo-controlled phase 3 study to be superior to azacitidine and placebo, and markedly so, whether it was event-free survival or overall survival, and the median overall survival went above 20 months, which is highly remarkable. So now you have these two options for patients with IDH1 mutations. If you give them HMA-VEN, that's not so bad either. Those patients also did pretty well, that subgroup with HMA-VEN too. So it's a remarkable option for those patients. So Dr. Dover and his colleagues at the MD Anderson here, Tapan Kadia, published recently some very impressive results of cladribine, LDAC plus venetoclax, alternating with HMA and venetoclax in patients who are older, and I believe it was age 60 and up, and showed a very impressive survival curve here, as well as a very high rate of composite remission. So venetoclax is sort of a dancing partner. You kind of give it with something else and it just makes things better, at least in terms of efficacy. And not only do you have a very nice rate of composite remission, a good number of them were actually MRD negative. It just shows you sort of the depth of remission. Where these combinations will ultimately go in comparison to HMA, venetoclax is an open question, but they will require additional study. Here are two other studies published recently, one with FLAG-IDA and venetoclax, and CLIA and venetoclax, both more intensive options, plus the BCL2 inhibitor. One thing I will mention, we have limited amount of experience in Boston with 7 and 3 and venetoclax. In general, it gets tricky when you combine venetoclax with intensive regimens, because you do worry a little bit about fairly severe marrow suppression. So I think dosing and scheduling is very important, and figuring that out. And I think the folks that have run these studies have done a lot of work to try and demonstrate what is the best way to sequence and dose these therapies and combinations. All right, I think I went through that fairly briskly, but I think we maybe have about a minute to sort of talk about the previous section. I don't know if Dr. Dover, what your thoughts are about venetoclax and combinations, and how you use HMA-VEN in your group of patients.
Yeah, I mean, absolutely. I think the HMA-VEN combo is highly effective. Nicely you brought up the IDH issue. I mean, I think if this patient had an IDH mutation, then the big question is, do you use ivositinib for the IDH1 or HMA-VEN? And, I think that's something that we will likely not truly be able to resolve, because I don't see anybody planning to randomize study of AZA-VEN versus AZA-IVO. But the data looks very good with the AGILE study, the 24-month median survival. But of course, the caveat is you have to get the mutation result, which I think in big academic centers and in a lot of Europe where this study was done is now happening within 4 to 5 days. But in most community, and even in many academic smaller centers in the US, could take 2 weeks. So I think in that scenario, I probably would not want to wait 2 weeks. I really just move with HMA-VEN and then leave the IDH for the next stage. So I think, data is one thing, but logistics and practicality often have to be taken into account. But yeah, and as you mentioned, we are looking at combinations with cladribine low-dose RC, which looks very, very encouraging in this 65 to 75, 80 group population, as well as the intensive chemo-VEN, which is quite myelosuppressive, but for the younger, very fit, selected patients, could be a very good option.
So I want to put you on the spot, because you're good on the spot. Let's say you do get the IDH1 mutation back in time, and your patient asks you the options on the table, and you sort of go through HMA-VEN, you give the data, which is there, and you go through AZA-IVO. And how do you make that decision for the patient, and what do you usually decide?
Yeah, I think most educated patients, right, if you actually show them the data, I mean, we often compare about statistics and the issues of cross-trial comparison, but in reality, in most human decisions, we actually just get to see what we get to see, right? And we have this data. So Dan Polier recently published in Clinical Cancer Research with IDH1 mutation. It was 15.8 months, the survival. And this one's 24 months. So, I mean, I think if I showed these two to the patient, he would say, well, if there's no equipoise, then 24 looks better than to me. And that's the reality, right? And until and unless somebody's a randomized study, I think we will be stuck with these cross-trial comparisons. And in that setting, the 24 does look better than what we've seen with AZA-VEN.
Yeah. All right, yeah, so I had a patient recently, that's the reason I asked that, who did the exact same math. And he was like, well, you give, 15, 16 months, you get HMA-VEN, but then if I progress, I guess for relapse refractory ivosidenib, what is it, about 9 to 10 months. So it comes out exactly to 24. And if I get HMA-IVO, I'm not sure if there are any options. I was like, dude, you got to stop with the math. Yeah. Let's just pick one of these, and then we'll go with it. It's a tough one. I think for me, I don't think there is a right answer, but I will say that HMA venetoclax is a bit more cytoreductive. So if you have a patient who is quite proliferative, I worry a little bit about using HMA-IVO in that setting, because it does take a bit longer to achieve marrow response, and you may not have sort of the time and space to not get in trouble, at least during the first few weeks. That's one potential consideration. The other one is the side effect aspects differ, right? So differentiation syndrome is also a concern with ivosidenib, and something you need to think about. So with that said, let's just go through the next case, and I'll hand over the podium to Dr. Dover. So Carol is a 70-year-old patient with hypertension and diabetes, good performance status, unfortunately diagnosed with AML, I assume has normal cytogenetics and a FLT3 mutation. So is VEN-based therapy still an option? It's a good question. How about a FLT3 inhibitor combination of some sort? How would you combine it? Is transplant the right approach? And after transplant, would you consider FLT3 maintenance therapy? And finally, a lot of the work that Naval himself has done quite a bit of are combination therapies outside of traditional chemo with FLT3 inhibitors.
All right, yeah, thank you. I mean, I think those are the questions we all grapple with, and of course I didn't mention, but there is the approach of could you combine them up front, AZA-VEN, IVO, and Dr. Donardo and others in our group are looking at that. So hopefully in a couple of years we'll have all these 3 data sets matured and be able to make those decisions. And in FLT3, I think that same thought process is moving even more quickly, and I'll kind of show why we think for FLT3 there's an urgent need to kind of improve current therapy for older unfit patients. So these are the NCCN guidelines for patients with FLT3 mutated disease. Induction with midostaurin based on the RATIFY study is the current category 1 guideline for this population, but there is also emerging data with quizartinib that I will show you, which looks also quite encouraging. So this is the 3+7 midostaurin versus 3+7 placebo. You all have probably heard about this and seen this slide many, many, many times. This was actually the first of those 9 drugs that got FDA approval. And here you see that the survival was improved, but the absolute survival benefit was about 7%. Nonetheless, as we discussed, this is incremental progress. And then once you actually took these patients to transplant, which should be the goal, and in the recent years, we actually are transplanting a big proportion of our younger than 65, 70 with FLT3 mutated, you could really start seeing encouraging survival with 4-year survivals getting above 60%, which is very good given that FLT3 mutated disease 2 decades ago when it was first identified, the 5-year survivals were in the 20-25% rate. But again, using the FLT3 inhibitor and transplant is really where things started to improve quite a bit. So could you then start using a better FLT3 inhibitor? Midostaurin, sorafenib were the first generation FLT3 inhibitors. These were good drugs. They were not really designed specifically to be FLT3 inhibitors. Sorafenib, as you know, has been used in liver cancer, bladder cancer, but we found that they also targeted FLT3. But then there was a new group of drugs, quizartinib, gilteritinib, crenolinib, that were actually designed as specific FLT3 inhibitors. And one of them has already completed a frontline study. This is the frontline quizartinib +7+3 quantum first study. Now there's 2 kind of big differences between this study and the RATIFY, which I think is important to highlight. So one is that the quantum first allows patients 18 to 75 years of age. So even though the label for midostaurin says 18 to 75, the population actually enrolled in RATIFY was only 18 to 60. And in fact, 40% of the patients in the quantum first were above 60, which is a more difficult population in general with more myelosuppression toxicity. And the second is that these are all ITD patients, 100% in the quantum first, whereas in the RATIFY, only about 75% were ITD because it allowed TKD. And in general, ITD tends to be a more powerful adverse driver. So I think in the future, as we get the subset data from quantum first, looking at ITD alone below 60, we'll start getting better ideas to where to put this in the setting of the ratified data. So this was the data that was shown at EHA meeting by Dr. Harry Erba. You see median survival is improved, 31.9 versus 16.8 months. There's about a 10-11% absolute survival benefit at 3 years. That's good. And overall, the tolerability was as expected. There were no new safety signals. There has been a lot of concern over the QTC with quizartinib. A lot of that was at the older high doses we were using. For some of you who may remember 8-9 years ago, 150, 180 milligrams, we did see potent QTC prolongation, but now at these lower doses, this study, for example, uses 30 and 40 milligrams, the incidence of grade 2 and higher has been very low, and we have not seen cardiac issues clinically with this. So I think that it looks like a good combination. That being said, of course, monitoring should be done. If one starts giving multiple QTC prolonging drugs, azoles and Zofran and things like that, then this could lead to QTC. But in general, with good awareness and monitoring, we have had not a big issue with quizartinib. Maybe I'll turn it to Amir. So what are your thoughts on the frontline data? And since you put me on the spot, I'll put you on the spot.
Sounds good.
So
you have better answers than I do, so I think we're in good shape.
So,
no, I think it's an exciting time.
Yeah, what do you think between Mido, quiz? How will we select? What would be the things you want to see maybe from the quantum first data?
I think I've already seen a very good amount that is very exciting and interesting. I mean, I think it appears that the survival advantage is relatively similar to what we saw with midostaurin. I do think that quizartinib is a more potent selective FLT3 inhibitor, and I think in that sense it may allow patients to have deeper responses. Of course, the side effect profile needs to be kept in mind along with QT prolongation, but from what I've seen so far from the trial, that seemed to have been relatively mild to moderate.
Yeah. Yeah, I think it'd be good to see more of the final publication and some of the subset data, and then, you know, hopefully we'll
Yep.
have a more detailed story. So as Amir mentioned, what about the older unfit, right? So AZA-VEN, is that it? Are we happy with AZA-VEN for all molecular subsets? Now TP53, I think we all agree, in fact, AZA-VEN is not doing much more than HMA alone. And FLT3 is probably the next bad actor, where the combination, a little different from TP53, actually gives you good response rates. That's not the problem. 65-70% is very, very healthy response rate, but the survival is unfortunately not as good. So Marina Konopleva published this data recently in Clinical Cancer Research, where with HMA-VEN in FLT3 ITD, the AZA-VEN survival was 11.5 months versus AZA placebo 8.5. So it's still better, but very marginally better. So what can we do next? So this is where a lot of efforts are ongoing, initially in salvage. We're not discussing that here today, but we have done VEN-gilteritinib combo. We published that in JCO recently, showing very encouraging synergy and response rates, and now moving it up front. So this was a recent retrospective analysis. Prospective 2 studies are ongoing, but retrospectively we looked at patients who received HMA-VEN FLT3 in the last 2.5 years at MD Anderson. And at least on the surface of it, the signal for both CR/CRi as well as true CR rate, which was 67 versus 32%, looked good. And the early mortality, in fact, was similar, actually a little bit numerically lower, 7 versus 10%. So we think that these can be potentially delivered. Of course, this needs to be looked at both in randomized single arm and eventually, hopefully, randomized studies. And to that extent, there are 2 ongoing studies with Dr. Nick Short and Dr. Musa Yilmaz. I don't want people to memorize this, but I think the key here is that these are still clinical trials, and we're still optimizing dosing. This is not 1 + 1 + 1. So I do not think well, we know you cannot give VEN 21, 28 days, gilteritinib 120, or quizartinib 60. That is going to be myelosuppressive. So we have to adjust, just like you heard a lot in the ALL session, how the doses of ENO and Blina, et cetera, were adjusted. And currently what we're doing is we're doing 14 days of venetoclax, and in fact on day 14 we're doing an early marrow to see if we're already achieving marrow clearance or remission. If we do, we consider holding the FLT3. So maybe 14 days of both of these with HMA is quite sufficient, and this data will be updated at ASH. And eventually I think that if HMA-VEN becomes a good background, this would be a good combination, but not really for the 84, 85-year-old. I think this is a good one for the 60, 65, 70, where you could push through intensive chemo with 10-15% mortality, all of those things. But maybe if your goal is to get to transplant, this could do this smoother and more efficiently. And again, the AZA-VEN study that Amir is doing may help us get to that point. So I think here, in the interest of time, I'm going to just very quickly go through this case, Amir, and turn it to you for the last session, and then hopefully we can take a few questions in the last 8 to 10 minutes. So this is a 59-year-old NPM1 DNMT3A, 75% blast, induction, 2 consolidations, let's say with high-dose cytarabine. She's in CR. She absolutely, you've discussed 5 times with her, does not want to do transplant. We all would want to do transplant here, but we have patients rarely, after listening to everything, they say, we don't want to do transplant. So the next question, what do? Do you just stop, wait, observe, we're done, give multiple more inductions, or do you go for maintenance approaches? And in the if she were to go to transplant, would you still consider maintenance? So I'll turn it over here to you.
All right. The NCCN guidelines regarding maintenance, pretty brief up until recently with the approval of oral azacitidine. So let's get to the data. So this is the big ticket slide, the QUASAR study, the phase 3 study that looked at patients who had received traditional induction therapy and some cycles of consolidation mostly, and who thereafter were deemed to not be candidates for traditional conventional stem cell transplant. Those patients either received oral azacitidine or received placebo, and as you can see here, there is a gap between those survival curves with a median overall survival of 25 versus 15 months, and this has led to the approval of this agent for patients following conventional upfront therapy for AML who do not have options for consolidative management, including transplant. Factors that were associated on the QUASAR study for long-term survival were intermediate risk cytogenetics, the presence of an NPM1 mutation, and as well as achievement of MRD negativity. Those three were the big items that predicted better survival. MRD positivity in general, according to multiple studies that have been done with various forms of MRD assessment, is associated with adverse prognosis. In fact, that's one thing we do know about AML and MRD, is that it's prognostic. It's not necessarily predictive in most instances, but it is prognostic. In this setting with Quasar, oral azacitidine significantly improved overall survival regardless of whether the patient received placebo and independent of baseline MRD status. So if you received oral azacitidine, had MRD or not, you did better. As you can see, those survival curves are both separate and significant, perhaps a little bit with your eye wider distance between the lines with MRD positive at baseline. And so patients treated with oral AZA were more likely to achieve MRD negativity and had longer overall duration of MRD negativity, which is also important. The NPM1 mutated group seemed to do particularly well. The sort of the curve that stands out in terms of both overall survival and relapse-free survival are those patients who had NPM1 mutations and received oral azacitidine. So those patients did really, really well, and it seemed that oral AZA was very helpful in that regard. So just some items regarding safety and tolerability. GI events were seen and predominantly seen in the first 2 treatment cycles, as well as cytopenias, which required closer monitoring, and that is recommended every other week and as needed thereafter. Recommendations in general, besides close monitoring, is prophylaxis with antiemetics as needed, and as I mentioned, in my experience at least, these tend to get better over time. Just to sort of go through these relatively quickly, I'd like to leave, if I can, with a few minutes for questions. Other attempts at maintenance, the RATIFY study with midostaurin looked at midostaurin as maintenance and did not show a substantial DFS difference. The SORMAIN study is actually looking at sorafenib, another FLT3 inhibitor, but in the setting following transplant in FLT3 mutated patients, and showed a RFS advantage, which was quite exciting. Another study from China showed a survival advantage also for sorafenib following transplant. The Quantum First study has also been looked at in patients following transplant, and it appears that the duration of CR was longer with quizartinib. So that is also quite exciting. So I went through those pretty quickly, but I thought it'd be good for us to sort of sit down and go through some of the questions that the audience has asked. Thank you so much.
Fantastic. Yeah, thank you very much, Amir. So let's see, we have a few questions here. So one of these questions is, would you consider oral AZA as a post-transplant maintenance option? So I'm going to turn that to you, Amir.
I believe that's being looked at, but that is not currently what is recommended or approved. So I probably would not use that in that setting right now conventionally for a variety of reasons. You know, post-transplant is a tricky environment. You know, you have to worry about things, specifically GI, GVH, GI toxicity, period, liver enzyme issues. So in general, I think it's a difficult area, but it requires investigation. And if it shows that there is promise post-transplant, I think ultimately that's something folks can potentially look at.
Yeah, I totally agree. The Amadeus study, I think is the one you're referring to, is being completed in the UK, and randomized post-transplant oral CC486 study, and will hopefully answer this question. So this question I can take quickly. All the patients with mutations in TP53, do they have a poor prognosis, or are there some mutations that do not? And Dr. Fathi briefly alluded to this. So the broad majority do, especially those with higher allelic burden or associated high-risk cytogenetics like deletion 17 or chromosome 5-7. That's about 75-80%. But there are some patients, and Nick Short from our group and David Solomon from Moffitt have published 2 separate papers, came out at the same time with similar data, that if you have less than 20% TP53 VAF and happen to have a diploid or non-adverse cytogenetic, there could be this group that actually did quite well with cytarabine-based therapy and transplant. So, and of course, once you get into detail of the specific mutation and its functional impact, is it a gain of function, loss of function, frame shift, there are further heterogeneity. So Not all, but in today's world, until you have detailed genomic sequencing, VAF, cytogenetics, I think we tend to treat most of these as adverse going forward. Let me ask you this one. Is there any clinical experience with lower dose CPX in older therapy-related or secondary AML?
I know that the folks in industry are looking at various dosing approaches of CPX. I don't think there is anything that is recommended for conventional use. We already adjusted the number of days that patients get CPX, whether it comes to reinduction at mid-treatment or with consolidation. But beyond that, I don't recommend adjusting the dose of CPX for older patients.
This is an interesting, we didn't talk much about relapse just because of the constraint of time, but this question kind of brings a little discussion into that. So when in the course of targeted therapy for AML is differentiation syndrome likely to occur? Differentiation syndrome is a growing entity that everybody, I think, needs to get more and more aware with. We saw this with IDH inhibitors in salvage, but that was kind of milder and well managed. Still, you have to be aware of it and manage it. Now with this group of menin inhibitors, which I think are very, very important and hopefully major drugs for relapse setting, 5 or 6 of these in clinical trial, we again see differentiation syndrome, and the timing is very hard to predict. So we see it anywhere from a few days all the way into months into the therapy. So I don't think that there's a fixed time period. If I had to give you a general idea, that's more common in the first 2 months or so, 2 to 3 months, but you could still see it out later. Your thoughts?
I just to sort of piggyback on that, I do think that there's probably some, just over time we've realized some variability and heterogeneity when it comes to differentiation syndromes as well. There's differentiation syndromes, or the traditional one that you tend to get with ATRA and arsenic with APL, and similar one with IDH inhibitors. I think some of the newer classes of drugs that are emerging probably have some heterogeneity regarding the type of syndromes that emerge as a result of differentiation responses to therapy that could be more robust, that require probably a better characterization.
And then this last question I'm going to do, because I think it's very important. In your practice, do you do NGS panel in all patients in diagnosis? Absolutely, yes. I think for that question, I have no ambiguity. We should do it. Now, do you wait for the full NGS? Probably not, right? Right now, FLT3 is actionable, IDH in the older patients, maybe if you have trials TP53, and there are trials coming for frontline menin, so MLL and NPM1 may fall in that bucket. But I think we should do it today. There is prognostic value to this. The recent ELN as well as ICC and WHO will now all include a group of secondary mutations that are considered high risk, RUNX1, EZH, others. So I really think that, and of course if we have this data, then we can use this for future treatment decisions. So I would definitely get it done for your patient, even if you don't wait for that data necessarily.
No, I agree, and I think one of the first slides that Naval showed were sort of the number of patients that don't even get mutational analysis, and that type of data that really worries me. You see a patient in the community who is maybe older, maybe has 77 or 78, and they come to see me still, where their local physician says, well, they said that because of my age, I'm probably not a candidate for therapy, and they recommended, very gentle therapy or no therapy at all, without looking at mutations. And that's tough. In this day and age, I think that's inappropriate. So I do think that we need to have data for all patients, IDH, FLT3, and soon maybe NPM1, KMT2A, P53. And many of these you need to check at points of disease evolution or relapse, right? So especially FLT3 can play a lot of peekaboo, so, if it's there at first, it goes away at relapse, and vice versa. A lot of these alterations do. So you don't want to miss the opportunity to potentially prolong a patient's life, especially a younger patient. I've had patients who've relapsed the 4th time, and you're about to go in there and talk about end of life, and all of a sudden the NGS comes, or the mutational analysis comes back, and patient has a FLT3. I have one patient just like that in her 20s, who, because we found the FLT3 mutation on her 4th relapse, is still alive a year and a half later. So these are all very important aspects of caring for patients, is to better characterize these diseases.
So I think the summary is that we have a lot of great tools. Now the next decade is going to be how to optimally use them, and hopefully we can reduce the need for intensive chemotherapy. I'm always envious when I see the ALL and multiple myeloma talks. Maybe we can be there in the next 5 to 10 years. But yeah, I would like to thank you all very much.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/NQY860. This activity is supported through independent medical education grants from AbbVie, Bristol Myers Squibb, Daiichi Sankyo Incorporated, and Jazz Pharmaceuticals.